I'm the clinical director of the North Carolina Regional Extension Center, and I'm going to talk to you today about the effect of having a practice reach meaningful use with their EHR and then go on to have practice facilitation to do quality improvement. And today I'm going to talk largely about diabetes outcomes, but because we've worked on those for a while, but we are applying the same principles to the four major measures of the Million Hearts outcomes. And so the techniques will be exactly the same. So our goal in doing this, once we started thinking about meaningful use and quality improvement, is we initially wanted to pick the measures that had essentially the biggest bang if we could improve outcomes over time. And so as you can see for diabetes, it's a pretty important situation to get under good control. And I'm not going to belabor all the points on this slide, but you can see that everything from life expectancy to the cost of care is affected very radically if diabetes isn't well treated. So in North Carolina, the prevalence of diabetes is 9.6%, which is about a percentage point higher than the national average. But if you look at patients enrolled in the Medicaid program, that number goes up to about 15.7% for adults at a cost of over $500 million per year. And so thinking about quality improvement a second, at the North Carolina Regional Extension Center through the North Carolina Area Health Education Centers program, we got involved in quality improvement starting back in 2007 through the Improving Performance and Practice program. And for initially, the pilot was with 18 practices, and we had a partnership with Community Care of North Carolina, our state Medicaid organization, and CCME, our QIO, along with the Medical Society and the primary care organizations in the state. But the main basis of our program is we wanted to use Institute of Healthcare Improvement style quality improvement techniques along with Ed Wagner's chronic care model. And so we had meetings that were essentially regional collaboratives where we brought in experts and practices got to share. But the main intervention was practice facilitation, where we trained quality improvement coaches to actually go in the practice, work on being able to measure diabetes care, and then work on the practice workflow and the roles of practice personnel so that quality improvement could really get done. And so between 2007 and the end of 2009, we actually grew across the state to where we were working with 180 primary care practices, and many of these were doing diabetic quality measures, which they reported to our central database monthly. So initially in this program, health IT was not on the radar screen, and so in gathering data from practices, we basically used Scotch tape and baling wire. Some practices we had used registries which they had to hand populate. Other practices had EHR systems that did not easily provide quality reports, but we were able to work with the systems and get reasonable reports. And then thirdly, we actually had a fax system where we could, through a fact sheet, upload data that practices then get later through a website. But anyway, in 2010, we became the North Carolina Regional Extension Center, and all that patchwork stuff went away. Our job then became to get these practices onto electronic health records and then be able to achieve meaningful use, after which we would segue into quality improvement work and organization that represents patient-centered medical home functionality. So this practice facilitation work plus the REC activities became the North Carolina AHEC Practice Support Services. So by 2011, participating practices covered 113,000 diabetics, and again, at that point it was still early in the EHR process, but with the systems we had, we saw this marked improvement of hemoglobin A1Cs less than 7 from 23% of the diabetic populations cared for by these practices all the way up to 47%. And using UK-PDS data and extrapolating it to this over 100,000 patients involved, you could actually project that about 2,000 lives could be saved over 10 years by maintaining this kind of control. Now, since hemoglobin A1C less than 7 was the original currency back at the beginning, we'll still report that number so that you'll be able to compare apples to apples in the combination of meaningful use and quality improvement work. So in this report, we're limiting it to practices that have actually participated in the Regional Extension Center and had practice facilitation and have reported data for at least 6 months in 2012 and or 2013. So we're talking about the first 50 practices with 209 providers who have fully participated in the electronic health records program. So these current data actually apply to 26,300 diabetics, and in this statistical analysis, we'll give you descriptive data about the practices and the diabetics, and we also present results on multivariate analyses that will control for group, and by group we mean how far along they are into meaningful use, by whether or not a practice has a rural location or not. Also, we'll look at payer mix, the number of providers in the practice, and what we call quality assessment scores that show how organized the practice is. The leadership score applies to how well the practices can independently do quality improvement, IHI style type work and organization. Self-management teaching, have they actually developed a program where they teach patients well about self-management skills, and also has the practice built protocols and algorithms of care where they have standing orders and things can happen automatically without necessarily having an acute physician order. So these are the demographic results about the practices, and as you can see, about 2/3 of the practices were rural in location, and the payer mix had lots of Medicaid and uninsured patients. These were largely small practices with an average practice size of 4 providers per practice. And on the QI assessment scores, they were really pretty good with leadership and QI type skills, but the self-management skills were kind of middling. Protocol skills were pretty good. And these are the data currently. And so Group 1 represents the practices that really aren't using their EHRs well, and they are doing quality improvement work, but they aren't able to produce regular reports. Group 2 are the practices that have automated quality reports directly out of their EHRs and also have the practice facilitation folks and the QI. And then Group 3 are the practices that have fully reached meaningful use and again have practice facilitation and are actively involved with quality improvement. And so as you can see, as practices gain EHR functionality and reach meaningful use, there's really great improvement over time. Group 1 is kind of in that neither land of the early practices. Group 2, the statistics are kind of in the area that we were stuck in before we got the well-functioning EHRs. And the Group 3 folks that have fully reached meaningful use, they've reached a new level. And to give you an example, in Ahoskie, North Carolina, which is a small town in the eastern part of the state, it's a town that's lost many manufacturing jobs, has many uninsured patients, and is essentially economically struggling. And Roanoke-Chowan Community Health Center, the FQHC in that town, literally with this quality improvement work for their hemoglobin A1Cs less than 7, they're approaching 80%. For the hemoglobin A1Cs greater than 9, they're down to the 9% range, and the LDL cholesterols less than 100 are also 70%. So, I mean, you think of major academic centers, but this health center in a small North Carolina town in an economically disadvantaged community are essentially producing benchmark numbers with the combination of meaningful use and full functioning quality improvement. So in the regression analysis, when we control for the independent variables that I mentioned, for those of you who have done any kind of statistical analysis, when you're in kind of a psychosocial behavioral system, when you get an R squared of 0.25 or 0.3, you feel like you're in heaven because that's a relatively powerful statistic. But the R squared for this model was actually 0.62. And the main thing that predicted great outcomes with high percentages of hemoglobin A1Cs less than 7 under control basically was the fact that the practice was fully functional at meaningful use and did practice facilitation. Being in Group 2, getting automated quality reports actually predicted better function, but it wasn't as good as full meaningful use. And then another interesting result is that the practices that were smaller with a low number of providers actually got higher percentage control of these parameters that I've talked about. And it kind of makes sense because when you think about it, in a big organization, to really move the needle, you have to get a bunch of providers on board using excellent tools to their best result. Whereas if you give a small practice excellent tools, I mean, it's basically like steering a speedboat rather than a big ocean liner. Those practices are very facile and can move quickly if they're committed and they have the tools to move with. Now, most studies that have been published looking at EHRs leading to some improvements in quality. They were studies that were done by big organizations like Geisinger and Kaiser, where the organization is actually in control of the system and really employs all the providers, so they have that kind of uniform policy. But in the data that I'm reporting to you today, these practices are not organizationally related, only the fact that they participate with meaningful use through the Regional Extension Center, and they engage our quality facilitator / quality improvement coaches. So they're practices from every region of the state. They're small practices and some bigger practices, different organizations, different affiliations, different payer mix, but they were still able to improve these very strong results. And so why the new leap? I mentioned that we were kind of stagnated in the middle, and now things are rising again in terms of important care measures. And what I have on this slide are some of the tools that the computer will give you. It gives you the consistent data. You're able to do the population drill downs. I'll get back to that a little bit more in a minute. And you're able to get good point of care reminders and templates for care. But let me give you an example on these population drill down lists. Okay, if I put in my computer that I want a list of all diabetics with hemoglobin A1Cs of 8.5 or higher who haven't been to the practice in the last 4 months, then I have a list in front of my face. But unless I have a system to deal with that list, what am I going to do with those patients to bring them in, teach them about their medicines, make sure that they're adherent, make sure they have the self-management skills, and make sure that I have protocols where I can intensify care between visits? Unless I set up a system that includes all those things, the population drill down lists don't mean a thing. So this is a combination of how do I use my tools, how do I use my computer, how do I use my meaningful use, and how do I organize it in a way where people in the practice have roles and they're all working as a team in order to get things done. And that's what meaningful use has brought to the equation, because in order to get all the meaningful use measures done, the practice has to organize in a way where people have those defined roles. So having developed that experience, they can really relate to the practice facilitation and build these systems of care where they can really use their EHRs. So I like to show this slide. This is actually from the UK PDS article in the New England Journal that was published in 2008. And I want you to point your attention to the part of the slide in the lower right-hand corner. And so when people talk about diabetes outcomes, for instance, on the microvascular outcomes, well, if a patient has a little retinopathy, well, I understand that doesn't necessarily mean that they're blind. Well, there's a gray area. If their creatinine goes up from 1 to 1.5, they have a little bit of renal insufficiency, but that doesn't mean that they have kidney failure. So, I mean, you can argue with me about the fine lines and the gray area of all that stuff all you want. But look at that slide in the lower right-hand corner. That's death from any cause for type 2 diabetics. And I submit to you that there's no gray area there. You're either dead or alive. And the fact that you can achieve a little bit better control in the UK PDS study, the hemoglobin A1C was only dropped about 0.6 from a hemoglobin A1C average of around 8.2 to 7.6. So just with that bit of improvement, look at the drop in death. And again, that's what we're after in this program. And so if you apply that data to the further improvements that we've seen in this 26,000 patients, you can argue that another 10 years from now, we're going to see another 500 lives saved. And the difference between this, when you're working in the hospital and you do something, for instance, to prevent ventilator-associated pneumonia, or if you use low tidal volume ventilation, you can see patient improvements within a couple of weeks. When you're talking about chronic disease, you're talking about a window of 2 to 5 to 10 years. And so I'm not going to be able to walk through my practice and say, hey, Mr. Jones, you're the guy I saved by doing this work with meaningful use and quality, but I know that Mr. Jones is in there. So now I'm going to move a little bit to the Million Hearts, and so basically our AHEC Practice Support Program and Regional Extension Center, we've gone ahead and partnered with the North Carolina Division of Public Health to work together in the Community Transformation Grant. And in that situation, the Division of Public Health, through the local health departments, will be working on both policy and community organizational issues to provide healthier diet, lifestyle education, exercise venues, and policies that will help patients, again, on the community side, do things that aid with the important measures in the Million Hearts campaign. And on the clinical side, our quality improvement consultants will be working in practices on the Million Hearts measures in the exact same way we've worked on these diabetes measures that I've shown you. So thinking about John, whether John is 67 years old or 50 years old, John is a person with some difficult lifestyle choices and medical morbidities, who you can see by the case here has actually experienced a transient ischemic attack. So he's actually experienced vascular disease and had all these risk factors. And so thinking about the impact of the Million Hearts measures, first you have this idea of aspirin in people who have already had vascular disease, whether it's a heart attack, whether it's a TIA, whether it's peripheral vascular disease. But in this one study that happened to be published in the British Medical Journal, for every 100 patients in this situation in a practice who starts on aspirin therapy, you prevent 3 serious vascular events within 2 years, including 1 death. So again, simple intervention, kind of big bang for what you've done. And so if we control the blood pressure in these patients, then we actually decrease the risk of having a heart attack over the next 2 years by 20%, having a stroke by almost 25%. So again, something simple, dropping the blood pressure some, achieves a great clinical benefit. And then what about cholesterol? Well, by dropping LDL cholesterol 38 milligrams per deciliter, it's kind of the funny number because the actual measurement in the study was in millimoles and it was converted to milligrams per deciliter. But anyway, within 5 years, by not necessarily making the LDL totally normal, but just dropping it, these 38 points, you get a 20% reduction in ischemic stroke. So far we have aspirin use, blood pressure control, and cholesterol control. And then when we look at cigarette smoking, and again, this is a study that looked at 1.2 million women. And so these were all smokers, but if they quit by age 40, by the time folks were at age 70, for those who continued to smoke, the death rate was triple. So again, smoking cessation, even though it's hard to do, it's the big gorilla in the room. You get tremendous clinical benefit if folks can stop smoking. And so we've talked about smoking, cholesterol, blood pressure, and aspirin. And so the question is, if you put all these things together and throw diabetes and obesity in there, is there a cumulative benefit for working on all these things? And so this publication from the Journal of the American Medical Association in 2012 showed, yes, that all these things are cumulative. So if you actually make improvements in all 6 areas, you can reduce cardiovascular death by 75% and cut mortality in half. So doing all these things means something. So in thinking about the population that we work with in North Carolina, you can see that we've got a long way to go, that the cardiovascular death rate is substantial, that the annual cost of inpatient care alone is in the billions of dollars. And when you look at the 6 risk factors that I just talked about, we've got some work to do. And right now, the Regional Extension Center, we're working with a little over 1,000 practices that cover 3.8 million patients. And among those patients, you can see the numbers that have care situations, preventative things that we can really impact. And so, and getting the Million Hearts started through our CTG, Community Transformation Grant Initiative, there are 9 AHEC regions in North Carolina, and we're in the process of signing up 10 practices per region and working on those 4 measures plus diabetes that I just talked about. Again, using the combination of getting to meaningful use and then practice facilitation and then Institute of Healthcare Improvement style quality improvement techniques. So I hope you've learned by the data that I've shown you that MU plus QI equals GR8 outcomes. So we must reach meaningful use, and then we have to continue on. And finally, one thing I want to get across is federal incentives, of course, the meaningful use incentives are important. Of course they are, because some of these small practices need them to be able to survive if they buy electronic health records. So incentives are important. Pay for performance is important. Reaching medical home functionality and getting incentives for that are important. Accountable care organizations and shared risk and different payment models are important. But what are we really doing this for? I mean, we're doing it because we have a dream that community health is going to get better if we combine, particularly if we combine what we can do in public health with what we can do in practices, that people affected by these conditions will both live longer and have a much greater quality of life and hopefully never experience a heart attack or a stroke. I mean, the idea of being able to be functional into old age, to not having dialysis, to being able to see your grandchildren grow up. All those things are what we're in it for. And so when you're passing this message, you have to know the data and be able to pass it on. But the real life stories are important, of people who get their diabetes under control and then do well, who don't have heart attacks. Every story is important, but again, in this path, we have something that works. We can light the path and show practices that we can do little bite-sized things with these quality improvement techniques, and we really can work on something that's doable, that's measurable, that people can relate to. And again, it's the incentives are great, but this is about helping your neighbors. This is about a healthier community. So we need to really evoke the feelings that matter when we go after this. And so, again, these are the electronic health record things that provide the bite-sized pieces that we can show practices, but it's how we organize, how we use this information, and how we use teams and people in well-defined roles to get this work done. And I appreciate everyone that's willing to listen to this presentation. I wish you the best of luck in achieving these goals.